Hi, everyone. My name is Bryant Lee. I'm a Senior Technical Advisor for Health Financing, and I, along with my colleague Hui Ling, will be introducing an approach to costing called Activity-Based Costing and Management, or ABCM. So I'll start by asking a question. How many of you know how much it actually costs to provide HIV services in your country? And feel free to put any initial thoughts in the chat. In many places, the answer is not well known or is outdated. Also, traditional costing studies simplistically assume homogeneity across patients and providers, or only examines costs for one level of the health system. By using the ABCM approach, we can better understand the true cost of a country's disease program by revealing what resources are used in practice through direct observations and stacking costs at the above site, facility, community, and client levels. HP Plus has applied ABCM in 4 countries, Tanzania, Uganda, Kenya, and Mozambique. One of the main benefits of this approach is that you get a full picture of the total HIV program costs. At the above site level, which includes non-service delivery and program management costs, we use data from the PEPFAR resource alignment tool. At the facility level, we use something called time-driven activity-based costing, or TDABC, for 5 HIV interventions, and I'll go into more details on what this means in a moment. We costed community-level HIV support programs using a combination of resource alignment and implementing partner data. And lastly, at the patient level, we use the client survey to calculate out-of-pocket expenditure, travel, and opportunity costs borne by the client. So we identify these costs with some higher level objectives in mind. We want to inform decision-making and strategic planning for a more financially sustainable HIV program through routine collection of data and analysis. We want to be able to make more effective allocation of resources to optimize investments and to drive efficiencies. And we want to accelerate higher levels of country ownership. So going into TDABC in a bit more depth, it's a patient-centered approach, which means that we actually follow clients as they proceed through the HIV services at the facility. This approach consists of 4 main steps. Step 1 is to determine the care process, and we do this through key informant interviews to identify what activities are performed, who performs them, and for how long. Step 2 is to calculate something called the capacity cost rate, or the CCR, which is our main unit of measurement and is defined as the annual cost of each resource divided by how often in minutes the resource could be used annually. So taking the CCR for personnel as an example, we would divide a clinician's annual compensation, so their salary and their benefits, by what we call their practical capacity, which is the amount of clinical time a provider is available per year. And this does not include time for things like leave, sick days, breaks, and time doing non-clinical administrative tasks. Step 3, we have to account for consumables. And step 4, we have to account for overheads by allocating indirect costs. I'll now hand things over to Hui.
Thanks, Bryant. My name is Hui Ling Pan. I'm a senior associate in health financing with HP Plus Palladium, and I'll quickly go through the rest of the presentation. So the elements that Bryant just described can be visualized in what's called process map, as what's shown on the slide. In both Tanzania and Uganda, process maps show significant variations in care, even within the facility from patient to patient. We also notice that laboratory investigations are often skipped, which is contrary to Ministry of Health guidelines for ART services. And we see that provider-patient contact time is shorter in practice than what providers think is happening, especially in the lower level healthcare facilities, such as the dispensaries and the health centers. You can see from the example on the slide with all of those diamond-shaped decision notes that the 10 ART stable patients shadowed received slightly different care, with some receiving an extra session on health education, while others didn't, and not everyone went through registration and vitals, or even a consultation before they received their antiretroviral medication. When we stack all the levels together, an individual on ART costs the health system an estimated $237 annually in Tanzania. This number is a little bit higher in Uganda at $255. In both countries, commodities is the biggest cost driver. You can see from this bar chart on the left on the slide that in Tanzania, commodities comprise over 50% of the total cost. And this is followed by non-service delivery and program management at the above site level, which also comprise a significant combined 30% of the total cost. So what, you may ask? Now that we have this holistic picture and all of this rich information, how can countries use this information to improve resource allocation and efficiency? Well, we offer 3 ideas to spark some thinking and discussion. 1, given that above site costs comprise a significant portion of the overall spend, further investigations at this level may be looking into additional program data, may review opportunities for efficiency gains and redirecting resources to improve the quality of service delivery. 2, taking a closer look at the time-driven activity-based costing or TDABC data and examining variations across facilities and facility types and sub-patient categories, either via multivariable regression analyses or other more sophisticated analyses, can review opportunities to design quality improvement initiatives, which are expected to increase the cost effectiveness of HIV service delivery. Facility administrators can then use the TDABC data visualized in process maps to further strategize how to improve quality of care at the individual facility level. Lastly, you can see that commodities is a huge cost driver. And one of the advantages of a routine ABCM system is that it should allow for rapid assessment of impact on the overall program cost whenever there's a surge in commodity costs, such as what we see happening during the COVID-19 pandemic. For example, an interactive dashboard that would allow users to adjust input data, such as price of commodities, or maybe even taking a step further, more ambitiously in linking input data from routine data systems that already exist, will enable adaptive program planning, even if the end users don't have an intimate knowledge of the technicality of costing. So with that said, I would like to open the floor up for questions and comments. I hope you have lots of thought bubbles you would like to share, but also to spark some additional thoughts, we have prepared 2 discussion questions for you. Number 1 is, in addition to what we discussed, what other ways do you think ABCM data can be used to improve health financing and programming in your country or the countries you work with? And number 2 is, what challenges do you foresee in implementing a routine ABCM system? Scott, please go ahead.
Yeah, thanks a lot, Brian and Huling. This is very fascinating, and I might follow up with you outside of this forum. But in terms of data sources for the for this system, you mentioned you're going to do some kind of time and motion study, but what about for the commodities and for facilities costs, depreciation, or costing of capital goods and things like that, and for the above site costs? Where does that information come from typically?
So the above site data was sourced from the PEPFAR resource alignment tool. And a lot of the other data points that you mentioned at the facility level was collected through primary data collection. We partnered with a local research firm to conduct the implementation of the facility level data collection. So this was the time motion part, as well as the facility expenditure data, which was sourced from existing information systems, from PEPFAR implementing partners, and in some cases from the government.
And
Thanks.
Thanks, Scott. I see a comment from Victoria in the chat that this approach can be used to set up private wing services within government health facilities. Victoria, would you like to unmute and share a bit more thoughts on how you think, is it the ABCM approach or the specific use of the data?
Thank you. This is Victoria. Thank you for giving me an opportunity. For us, we see it as an approach that we can use to set up private wing services. We have, for example, regional referral hospitals where patients are not required to pay anything when they go for services, but there is a group that is interested in paying and then get a better quality service or spend less time at the facility. So we are considering using this approach to set up the private wing. Thank you.
Thank you very much for sharing your thoughts. Are there others who would like to share any thoughts or questions or comments? I see another comment just came in from the chat from Robinson saying that in determining insurance payments. Robinson, would you like to elaborate a little bit more on that?
Yes, my camera does not work, but at most times, like in Kenya, we are trying to get to universal health coverage where the national insurance mechanism would be reimbursing facilities for services provided. Mostly they are at challenge to know what the actual cost of providing that service is so that they can peg the reimbursement based on that. So this information would be very, very useful because the accurate figures are known. We know there is that $234 for that kind of treatment. So if we put a margin or a profit margin of 5-10%, we have at least a basis, an accurate basis for the determination of rebates. I think if the system can provide that information, if it can be expanded to the other types of services that are provided. Back to you.
Thanks, Robinson. So HP Plus is indeed conducting an ABCM activity in Kenya right now within the context of providing information for consideration of HIV and other essential health services to be included in the universal health coverage benefit package under their national health insurance scheme. And one of the aspirational objective of the ABCM activity is that some of this facility level results can be used to inform provider payment models and the rate levels under a health insurance context. And I see one more, actually two more comments just came in. One is to tell me to wrap up, but very quickly, a comment from Citi that when the costing results has been available, how does the project manage to have the related recommendations put into effect? Bryant, would you like to take that one?
Well, the unit costs themselves can easily be used to inform strategic planning, costing of national strategic plans. But part of what we're working on as a follow-on activity are thinking of what are the best uses of this data and how can it actually best inform the policy decisions, whether that's resource allocation, changing the way services are delivered. So there's a whole, suite of evidence that's coming out from this data that can help inform some of these important policy questions. Of course, it's a ongoing process, and we've partnered with a local research firm as well as a steering committee that serves as a governance role. So there's many government members in that steering committee, so that's a good forum for having these types of discussions.
And that wraps up our session. Thank you very much for this lively discussion. We shared a slide previously on some additional resources, which you can also find on the website on the HP Plus Innovation Cafe. Thank you again.